Well, good evening and welcome to the first workshop for our Anti-Stigma series. This is a project of the African Methodist Episcopal Church Publishing House, a project to reduce the stigma of HIV in Black faith communities. And this project is a series of sermons and workshops for AME congregations and for a larger Christian audience, particularly of Black faith communities in the Southeast, who we hope will continue the work and pick up new ways to do the work of HIV advocacy, both here and abroad. And tonight we are excited for the first workshop, a comprehensive overview at HIV 101 with our very own Reverend Dr. Miriam Burnett. I will introduce her and then I will turn the floor over to her for her presentation. The Reverend Dr. Miriam J. Burnett serves as the Supervisor of Missions for the 18th Episcopal District and the Medical Director of the International Health Commission of the African Methodist Episcopal Church. In June 2020, Reverend Dr. Burnett was appointed by the National Council of Churches USA as the representative to the World Council of Churches consultation with its ecumenical partners on health to discuss our responses to COVID-19 and its implications on the future of the health and healing ministry. In addition, Dr. Burnett continues to work with the national volunteer agencies active in disaster, or NOVAD. She is an ordained itinerant elder in the AME Church. And as of this year, in May of 2023, she was appointed as the convener of the relaunched National Council of Churches Health Task Force. Dr. Burnett is the president of Resource and Promotion of Health Alliance Incorporated, which is a health education and promotion nonprofit consulting company with innumerable years of experience aiding faith-based and community-based organizations as they strive to optimize health for their communities. As a minister and medical doctor, the Reverend Dr. Burnett is a strong advocate of holistic health, a concept that embodies physical, psychological, social, economic, and spiritual health. And this is powerfully explained in her speeches across the United States and across the globe. Dr. Burnett's well-educated, receiving a Bachelor's of Arts in Psychology from York College of the City University of New York, postgraduate studies from Queens College, and obtained a Doctor of Medicine from the Morehouse School of Medicine in Atlanta, Georgia. And Dr. Burnett, a U.S. Army veteran, completed her internal medicine internship and medical residency at Brooke Army Medical Center at Fort Sam Houston, Texas. She also has a Master of Public Health in Social and Behavioral Sciences, also from Morehouse School of Medicine, and a Master of Divinity from Turner Seminary at the Interdenominational Theological Seminary. She is, as you can tell, a well-educated, a well-experienced, and a well-poised person for this workshop. And so, Dr. Burnett, we thank you for being here with us today, and we turn it over to you.
Thank you so very much. It is my pleasure to be with you all. I thank you for the opportunity. One of the things I wanted to start out with why I chose my background. My background is a picture of Richard Allen, Sarah Allen, and others. And that's important to me. I am AME because of the public health work that is a part of our inception, part of our growth, part of our work. It's a part of our challenge. Despite all that happened with yellow fever, Richard Allen and those that worked with him sought to go beyond stigma, sought to go beyond the prejudices, but to empower and engage all those that were impacted by yellow fever. HIV is no different when it comes to the work that is required to us and for us. So if you can think of Richard Allen and yellow fever, then you can think of the AME Church today and tomorrow and HIV, COVID, and all of those other diseases that are present now and coming forward as we seek to improve the opportunities, improve the work that the AME Church and beyond, all of us faith groups coming together, working together, because it's very clear we will not be able to achieve the goal alone. So I start with our presentation for the evening. Let me make sure that I am actually sharing my screen, because I don't think I did that. Sharing my screen. And So we have several objectives this evening. First is, what is HIV? Then we'll talk about its transmission. What is PrEP and PEP? What are the resources that will allow a person to get this paid for? And then we'll conclude with what the church can do and what the church is doing. So what is HIV? Human immunodeficiency virus. It attacks the body's immune system. It's spread through what's called CD4 cells, or you might know them as T cells. Untreated HIV runs rampant through the immune system, through these CD4 cells, and decreases the actual number of CD4 cells. If left untreated, it can lead to AIDS, the acquired immunodeficiency syndrome, which means no longer or very difficult times happen with the body being able to fight off infections. The immune system gets damaged, leaving a person vulnerable to what's called opportunistic infections, as well as cancers. Treatment is the key, but even before treatment, it's prevention. But in order to know how to prevent it, one has to know how it's transmitted. HIV is transmitted primarily through unprotected sex, followed by breastfeeding and pregnancy, and the use of non-sterile syringes and tools. And that can mean tattoos. If the needles being utilized for tattoos are not sterilized or new. Then followed by organ transplant and blood transfusions. Those two numbers are greatly reduced now because of all of the testing that's done before the donation is carried through. You will find on the bottom of almost every slide, the CDC references so that you can pull down these pictures, you can pull down the information yourselves, delve deeper. It is very difficult to do this 101 in 45 minutes. I'm not even sure I'm going to make it. This course is normally done as a 3-hour course annually in the AME Church, and to drive it down to 45 minutes means you're going to have to do some of your own research. So what body fluids transmit HIV? Blood, semen, pre-seminal fluid, rectal fluids, vaginal fluids, and breast milk. These fluids must come in contact with mucous membranes and mucous membranes are found in the rectum, vagina, penis, and the mouth. Not only is this picture available at this website, but further explanation of these body fluids and what makes these body fluids even more susceptible to transmission. There are some more rare ways that HIV can be transmitted, but it's important to note them. One is oral sex, followed by workplace injuries caused by contaminated needles or other sharp objects. The blood supply in the United States, as well as the donated organs and tissues, are thoroughly tested and therefore very unlikely, and let me highlight very unlikely, I meant to draw several lines under that one could get HIV from blood transfusions, blood products, or organ and tissue transplants. Please do not avert the ability to get care for other things because of this fear. It's one of the things we fear that is essentially non-founded. Biting and spitting when there is severe trauma of tissue damage and presence of blood. There's no risk of transmission from unbroken skin. Deep and open mouth kissing is not transmissible through, it only transmissible if someone has sores and there is bleeding. You cannot transmit HIV through closed mouth or social kissing with someone who has HIV. It cannot be transmitted through saliva. Those are two of the things that are the myths, what we used to think. Food contamination only occurs in infants after the contamination occurs because caregivers' mouths have mixed with pre-chewed food and an infant eats it. That's one of those traditions that is old, that we need to eliminate from our practices of chewing a baby's food prior to before giving it to them. That's what blenders are for. How is HIV not transmitted? This slide has all of the myths that used to be, and in some instances are still available. You can't get HIV from consuming food handled by somebody with HIV. You can't get it from tick bites and other insects. You can't get it by hugging and sharing dishes. You can't get it from tears or sweat or shaking hands. It is not airborne. It does not transmit through the air. It cannot be on shared toilets. This slide, I recommend folks download from this website and paste it up on a wall somewhere so that everyone can see it. It is where part of our stigma, because of the myths that have been out there and are still out in some communities. This is how stigma prevails. Let's shift a little bit to what HIV is also about, and that's viral load. Viral load, you'll hear a term about the amount of HIV that is actually in the blood of someone who has it. It is highest during the acute phase of HIV and those without HIV treatment. Taking HIV medicine makes the viral load very low. You will have heard people refer to undetectable viral loads. That means the load is so low, it makes it very unlikely to transmit. It does not mean that the HIV is gone. The virus is still there, but it makes it so that it is nearly non-transmissible. The opposite end of that is HIV superinfection. A person can get several types of HIV or strains of the virus. Let me bring this home for you. When we talk about COVID, we talk about variants. Similar. A person can get one type of HIV or strain of HIV, and without treatment or with repeated exposure can gain another strain that either replaces the original one or stays alongside of it. Taking medicine treats the HIV and can help someone from getting a superinfection. Please, one of the major factors that is important for anyone who has HIV is to make sure they are taking their medicine, taking it properly, and taking it consistently. Those three things must happen. I thought I'd run through the timeline. My entire medical career has been during the HIV/AIDS era. 1981, June 5, was the first official reporting. I will have you know that when I entered medical school, that's when gloves started being used all the time. It's when we had no idea what we were looking at. This is that era. By 1998, the CDC reported that African Americans accounted for 49% of the US AIDS-related deaths. That number has not changed much since 1998, 10 times that of whites. By July 2000, the US Congress said, oh, this is a global issue. And so they enacted the Global AIDS and TB Relief Act. That's a part of where PEPFAR came from. By 2002, there were 961,000 persons living with HIV in the US, with new infections over 50,000 per year. By 2003, and this number also has not changed much, over 2/3 of new HIV infections in the US are from those who don't know they are infected. Testing is key. So I've talked about medication, I've talked about prevention, now I'm talking about testing. Testing is key. Back in 2004, the number crossed 1 million, and it's still rising. In 2004, the Prep for Art program was launched in 13 different countries. By 2006, new testing recommendations were that everyone between the ages of 13 and 64 be screened at least once, with annual screening for those at high risk. It is now an opt-out. You have to say, I don't want it. So that we can decrease those numbers of people that don't know. Let's go back to prevention, abstinence, not having sex, never sharing needles, using condoms the right way every time one has sex. One of the ways that we used to refer to and still refer to condoms is right way, every time. Right way, every time. There is also pre-exposure prophylaxis as well as post-exposure prophylaxis, and we'll go through details on those two. If I had more time, we would actually demonstrate how condom use is done correctly. PrEP, or the non-occupational post-exposure prophylaxis, or NPEP, was first released in January of 2025, when it showed that antiretroviral drugs could be beneficial after exposure through sex or injection drug use, begun within 72 hours after exposure. Timing is important. PrEP can be in pills or in shots. There are 2 pills approved, Truvada and Descovy. Truvada used for people at risk through sex or injection drug use. Descovy for people at risk through sex alone. It is not to be used assigned female at birth who are at risk for HIV through receptive vaginal sex. Then there is a shot. It is to be used for people at risk through sex who weigh at least 77 pounds. It requires an HIV test prior to each PrEP injection. PrEP reduces the risk of getting HIV from sex by about 99% when taken as prescribed. It reduces the risk of getting HIV by at least 74%. The pills are about 74% when taken as prescribed. The PrEP shots are not recommended for people who inject drugs. They are only to receive one of the 2 pills based on the risk. One of the questions that gets asked frequently is most insurance plan, and how do I pay for this? This is expensive. Antiretroviral drugs are expensive. How does it get paid for? Most insurance plans and state Medicaid programs cover PrEP. Under the Affordable Care Act, PrEP must be free under almost all health insurance plans. It's the almost that gets you. And that includes the medication, the clinic visits, the lab tests that are needed to maintain the prescriptions. But there's another way. PrEP is free or at a reduced risk for those without insurance or Medicaid coverage by 3 different means. One is the Ready, Set, PrEP. This link takes you to that site and gives the instructions. Available at no cost for those who qualify. There's a copay assistance program given by Gilead. Gilead is one of the pharmaceutical companies. VIV Connect offers a program to help pay for the shots. This is its website. It helps to lower the cost, and income is not a factor in eligibility. Some states have a PrEP assistance program, and this link takes you to your state's program. It asks a couple of questions, so you're directed to the correct website. This graphic takes you through, do I have health insurance? Yes or no? If I have yes, then use your insurance. If you still have a copay, there's assistance that can be obtained from the manufacturer or the Patient Advocate Foundation. If the answer is no, there is eligibility through healthcare.gov. Some of it's income-based, some of it is not. It's not a complicated slide, but it does take a minute to sit and look at. There are links that are on this slide that allow you to know how to get to a community health center where one is close to you, how to get to the PrEP assistance programs. These are all hyperlinks when you actually go to this website down here at the bottom. The other thing, please note that this this PowerPoint is only directed at the US and its territories. We would need a lot more time to go talking about global impact and how to get these meds. We can do that another time. There is also something called on-demand PrEP. It is an off-label use or used for intermittent, non-daily, event-driven, or the other ways that it's known for, but note that it is off-label. The FDA is not approved it, and the CDC is not recommending it. However, there are some states that are allowing it on a case-by-case basis. It's the 2-1-1 schedule. It means 2 pills within 2 to 24 hours before sex, 1 pill 24 hours the first dose, and 1 pill 24 hours after that. 2-1-1. There is evidence, scientific evidence, that it works and is protective for gay and bisexual men when having anal sex without a condom. However, we do not know how it works. Studies are still ongoing, which is why it is not completely FDA approved yet, or not completely not approved by FDA yet. And it is also a system that means that one has not been proactive. So not to encourage that either. We don't know how on-demand PrEP works for heterosexual men and women, people who inject drugs, and transgender persons. Like I said, there is some scientific evidence for gay and bisexual men, but beyond that, there is science is still evolving. Like I said, there are some health departments in the US and some health organizations in Europe and Canada who are offering guidance for gay and bisexual men at risk. But again, those studies are in large part still ongoing. This is how an estimated number of adults can potentially benefit from the full PrEP. And you will see total numbers of 500,000 for Black and African Americans, non-Hispanic, Hispanic close to 300,000, totally over 1 million. It's an important mechanism. Then there's the next kind of treatment or preventive measure is post-exposure prophylaxis. It has to be, must be, doesn't work without it, must be started within 72 hours of possible exposure to HIV. And those exposures include during sex, through shared needles, syringes, or equipment to inject drugs, or if one has been sexually assaulted. 72 hours is the key marker. PEP, post-exposure prophylaxis, is designed for emergency situations only. After a possible exposure, it is not a substitute for all of the other HIV prevention mechanisms. It is not the right choice for people who may be exposed frequently. And it is not to be used for repeated exposures. Please talk to your healthcare provider, seek treatment, go back to how do I get help? How do I go to the community health centers if you do not have insurance? And talk about PrEP. How do you pay for PEP? For PEP, post-exposure prophylaxis. Access this website, the CDC HIV Basics PEP, Paying for PEP website. You will gain access to all of these websites. After sexual assault, paid for by the Justice Department. After exposure at work, use the workplace health insurance or workers' compensation. For any other reason, it can be done through Gilead HIV or through a fillable form that will allow one to submit and gain access. Back to fact sheets about how do we deal and live with HIV. Major factor is to stay healthy is stay in medical care. Stay in care. Stay in support groups. Get medical attention right away and take antiretroviral therapy. And that is regardless of how long you've had the virus. Stay in treatment. Access how to get the antiretrovirals and learn how to protect others. Conversation is important. Conversation is important. Testing for other sexually transmitted diseases is also important. Sexually transmitted diseases or sexually transmitted infections, STIs, STDs, require increase the likelihood of spread. And so it is important, very important, to be tested on a regular basis if one is exposed. This same slide is available in Spanish. Please print and put it up everywhere. There are some key actions that I'd like to close with this section with in order to help end the HIV epidemic. Testing, testing, testing. In 2009, the AME Church began doing major advocacy around testing. We did testing at the General Board, and almost every bishop at that time got tested at the site of the General Board, went back to their districts and said, follow my lead. That was an important moment for us. 86% of people with HIV now know they have it, but we've got to get higher than that. We've got to get to 95%. I would prefer 100%, but nothing is 100. We have to prevent people without HIV who are at risk for it to be able to get PrEP, get it prescribed, and keep it. There's only 18% of persons who are at risk that have a PrEP prescription at this point. The target is 50%. Maybe it needs to be higher than that. Only 63% of people who have HIV are under control. The target is 95%. If you remember, I said under control, lower viral load means less likely of transmission. People who know they have HIV should be taking their medication daily to control the virus. At the connectional level of the AME Church, there is required clergy and lay leadership HIV training. The Health Commission conducts that training every year on the first Saturday in June. It is a 3-hour course. The HIV course is also available at all levels. It is required as of pages 248 to 249 of the 2021 Doctrine and Discipline of the AME Church. It passed regulation and legislation in 2016. So it has been in effect for a while now. HIV training, a minimum of 3 hours is the requirement. Let me read you the exact verbiage. Clergy at all levels and appointed or elected officers shall be required to obtain a basic scientific foundation to understanding HIV/AIDS. This can be summarized as what effective religious leaders should know about HIV/AIDS. Mandatory training shall be provided annually through each Episcopal district at ongoing or special planned sessions as directed by the presiding bishop or presiding elders. Each clergy person or officer is required to be certified and or updated at least once every 4 years through this offering. This offering can also be obtained and meets the mandatory training requirement if done through the Health Commission that first Saturday in June. The annual training should be provided with at least 3 or more contact hours. The content should provide understanding of current prevalence and impacts of HIV/AIDS pandemic in local communities and globally, the biology of the virus and its disease, community resources available, and practical ways for religious leaders to help eliminate HIV infection, AIDS, and death from AIDS-related causes. This is a graphic of the flyer that introduced the 2023 training. We had not only US, but global representation from the 18th Episcopal District. The year before was with the 19th Episcopal District. The M. Joan Cousins Center in Botswana is the leading HIV program in the country of Botswana, and it is utilized by much of Southern Africa. Started under the auspices of Supervisor DeVoe and Supervisor M. Joan Cousins. We talk about all the 4 requirements of the training. There can be a follow-up afterwards. And these persons are active resources. The person that started us on this way is no longer on this side of the journey. Reverend Dr. A. Oveder Fuller, virologist who sat on many of the boards of the FDA, sat on the board of the FDA advisory board regarding the COVID vaccines. She started us on this way. She passed in 2022, but our work is based on her work. She started many outreach education centers in Southern Africa, to include in Zambia and Malawi and South Africa. We must be about our Father's business. We must be about our mother's business. We must be about God's business. And dealing with and becoming effective leaders regarding HIV/AIDS is key. Thank you so very much for this opportunity.
Thank you, Dr. Burnett, for a really rich and generative presentation. There's a lot of info in here, and I'm sure that those who are watching will benefit greatly, hopefully with some new information and some new tools. There are 3 questions that I've gathered through some of our partner congregations, some of which you highlighted in the presentation, but I wonder if you could just say a bit more about. The first is what it means, we saw in the presentation, for the viral load to be decreased, or the words we hear, undetectable. One of the stigmas that we're hoping to combat, and that we hear often, even as you're sharing the graphic about how people think HIV is transmitted, is the stigma around those who do live with HIV. That they, there's a people to, in some people's, myths and their stigmas, to avoid, even sexually. But even as the graphic showed, saliva or dishes or hugs. Can you say a bit more about what it means to be undetectable, and how people living with HIV who are undetectable, particularly through the use of antiretrovirals, are still able to live flourishing lives?
Antiretrovirals taken appropriately, consistently, and I'll keep harping on that, consistently, decrease the viral load so that one's ability to fight infections is strong. The CD4 count rises, while the viral, they're in opposite directions. As the viral load goes down, the CD4 count goes back up, which makes one able to fight infections. Without CD4 cells, no ability to fight certain types of opportunistic infections. We used to hear about pneumocystis carinii pneumonia, PCP, and Kaposi sarcoma and other things. We don't hear that much anymore because with the increase of use of antiretrovirals, one can live a nearly normal life. It's I think one of the things that happened to the world is people got comfortable because viral loads were going down so far, and people were living normal lives and with normal longevity. And so the infection rate went up, the number of persons being infected went up, but the ability to be here forever, to be here as long as God ordains, rose. So it's almost like it's being categorized as a chronic disease, like diabetes and hypertension. You get it controlled, you can be here and not leave before your assigned time, or don't do what you're supposed to do, don't eat properly, don't take the medicine consistently, and become vulnerable to opportunistic infections, and that's when you move to AIDS.
Yeah, thank you. And even for providing that clarity for us, that there is a distinction between HIV and AIDS, whereas I think for so many, they hear the 2 terms, and so they presume them to be synonymous. But these are 2 separate things.
2 very separate things. AIDS requires a certain number of opportunistic infections. It requires a certain viral load. It requires a certain CD4 count. And so that AIDS is a diagnosis that has to be done by a healthcare provider, by a physician, primarily. Without that, there is no diagnosis of AIDS. It's truly a diagnosis.
Sure. One of the other stigmas, and I'm glad your presentation pointed to, and we've gotten in some of the questions, I think when HIV first emerged, there was such the stigma that this was a quote unquote gay disease. But as you're seeing, even in the presentation, and particularly your section about PrEP, the benefits of PrEP for heterosexual people is no different than it is for people who are non-heterosexual. So I wonder if you can speak a bit more to how HIV, like any other STI or STD, is not specific in terms of genders or sexualities in the way that people might think it is.
There are certain, they have even done the research on positions and access. The anal area is full of blood vessels that cause an increased receptor. But there is no difference when it comes to what body fluids and viral loads, and therefore transmission. And so to stigmatize, remember back in the older days, it was not only men who had sex with men, which is, we've also gotten away from using term gay and bisexual and gone to men who have sex with men, because that's about behavior rather than personality or who one believes themselves to be. So the behavior itself, the behavior of vaginal sex, unprotected in both cases, the behavior of injecting needles, the behavior of not taking PrEP and being pregnant and or having given delivery and breastfeeding. It's the behavior that's the important piece. To stigmatize a person for who they are is illogical. We all do things that our behavior says we should not do. So, but are we all going to blame each other for our behavior, or are we going to try to address the behaviors that put us at risk for everything? Let's use diabetes as an example. If a person is diabetic and eats all the candy, sugars, carbs they can get their hands on, in addition to that, does not take their medicine consistently or does not exercise, they are going to have diabetic end organ damage, period. But are we saying that every diabetic should be stigmatized? No. You'd probably be talking about 70% of the Black population. That's a number I just drew out of the air, but it does not make logical sense. Stigma is based in fear. It's based in non-reality. That's the nicest way I know to put that.
When I wonder too, this wasn't one of our given questions, but you're leading me to it. Why do you think, or do medical professionals, what is the opinion around why the rates of transmission and infection are higher, particularly within African American communities as opposed to others?
I think a lot of it, and some of the public health data speaks to this, that we did not do a good job of educating our people early on. And we allowed stigma to rule the day. Okay, so nobody wants to go get tested because I will be shunned. Nobody wants to be seen going into an HIV clinic because I'll get shunned. I can't talk about it in my church because that means I'm being sexually active. Come on, people. The fact that I even talked about and used technical terms during this presentation, I couldn't do 20 years ago.
Right, right.
And so we as a body of Christ have to get our heads from stuck out in the sand. Now you see what you did? You got me on my soapbox. We got to get our heads stuck out in the sand. We have to be honest with ourselves so that we actually can address the issues rather than the stigma and the fear and the hiding our hands, throwing the rock and hiding our hands.
Right. Absolutely. I mean, the number you showed about the percentage of people who don't even know that they have it and how that is increasing the infections, I mean, it's a very convicting charge, which leads to my last question, particularly for most of our viewers. What is it, as we think toward those last three slides and the last points about what we're trying to do to move toward the end of the AIDS epidemic, what is it that the local church can do? What is it that local congregations, how can they support this work? Is it through testing? Is it through awareness, advocacy? What are some practical things that a pastor or steward board can do?
All of that. Testing is available. The health department will gladly come to the church or other facility. There are mobile units that can pull up in your parking lot and get tested. Now, not only should that be available to the congregation, but it's a community outreach. Richard Allen, I go back to the very first thing I talked about. Richard Allen did not stay within the four walls. We are a part of community. We must make education, advocacy, testing available. There's always some legislation that is on the deck that talks about eliminating PEPFAR. If anybody looked at what was happening about 6 weeks ago around PEPFAR and its funding, it was in jeopardy. But do we know to advocate for it? Do we know to say, calling my congressman, making my congressman or my congresswoman, my congressperson aware that I stand up for the funds that are necessary for treatment, start with testing, education, and treatment? Has to happen. Because otherwise, Congress will do what they think they want to do. And especially in this era where there is so much stigma around every group, stop it. Become your own best advocate for your community. And if nothing else, that's what our churches should be doing. Opening up testing sites, taking people in vans to testing sites, bringing the testing sites to the community, partnering with the church next door, the synagogue next door, the masjid next door, because we are all in this together.
Excellent, Dr. Burnett. Excellent charge. For those of us who are on the line and for those who will watch this recording later, who will watch the stream later, to ask your pastor, ask your representatives to get involved at the church and in the community. Thank you again, Dr. Burnett, for a wonderful presentation, for joining us for this project. And thank you to all of you who tuned in tonight. We look forward to welcoming you again next week as we return to another sermon in our Anti-Stigma series. For all of Dr. Burnett's slides and for additional information, please visit our website, www.imame.org. We'll make sure that you have all of that information there so you can access those links. Other than that, be well, and we'll see you soon.